Well, we started the third table of OAFI Pre-Congress. The name of the table is the impact of COVID pandemic in OA research. And, we have three excellent speakers. One is Professor Leigh Mobasheri, President of Osteoarthritis Research Society International, UK, Finland. The second speaker is Professor David Hunter, Florance and CopeChair of Rheumatology at University of Sydney, Australia. And the third speaker is the Doctora Professor Leigh F. Callahan, Director of Osteoarthritis Action Alliance in United States. Well, the first speaker is the idea of the round table is more or less 10 minutes for each speaker, and later will be more or less 25, 20, 30 minutes, for discussion. Okay. The first speaker is Professor Leigh Mobasheri, President of Osteoarthritis Research Society International. Leigh Mobasheri is the president of as I mentioned, of the Osteoarthritis Research Society International, OARS, and professor of musculoskeletal biology in the research unit of medical imaging, physics and technology between the Faculty of Medicine in the University of Oulu in Finland. Leigh holds the position of Chief Researcher in the State Research Institute Center for Innovative Medicine in Vilnius, Lithuania, and is an Associate Professor in the Department of Orthopedics and the Departments of Rheumatology and Clinical Immunology at the University Medical Center, Utrecht, in the Netherlands. He is visiting professor in Harvard University, Boston, United States, visiting professor in South Yat-sen University, Guangdong, China, and Leigh was educated at Dulwich College London, Imperial College London, the University of Toronto, and the University of Oxford, where he obtained his doctorate from Wolfson College, Oxford. He is ranked as one of the top 10 leading experts in the world on osteoarthritis and expertisescape.com. That means that, is an excellent and important authority in the world of osteoarthritis, and also it's a good friend for me for years. And I really appreciate that you stay with us today, Leigh, and also to give your time to help to the patients from OA, the patients that we represent OAFI, Your speak is that the patient council activities in the European project approach, current and future collaborations between OARS and OA Action Alliance and OAFI. When you want, Leigh, you can start it. Thank you.
Thank you, Josep. It's a great pleasure to participate in this joint session and to be sharing the opportunity to speak with Professor David Hunter and Professor Leigh Callahan. I should also say that David is actually at the top of that Expertscape listing. He's the top researcher according to that ranking. I just happen to be number 8 or number 10 down the list. So this is a first opportunity to have a joint symposium with OARS and OAFI. And we've been planning this for a while now. We were hoping to have it face-to-face, but hopefully that will happen in the near future. So you kindly asked me to talk about patient council activities in our Approach project, which is a European Innovative Medicines Initiative project. And then at the end, I'll say a few words about the synergies between OARS, OAFI, and the OA Action Alliance and how we could work together in the future. So I've been speaking to the patients who form the patient council in Approach. And Approach is a 5-year Innovative Medicines Initiative program funded by the European Commission and the European Federation of Pharmaceutical Companies, which at the time of inception included Merck, Servier, GSK, and also the academic partners. I'll show you a slide including their identities and who they are. So the Approach project was actually funded through the IMI-1 mechanism, which was the latter end of the Framework 7 program, which was funding research before Horizon 2020. Now we're into IMI-2, but Approach is ongoing, and indeed we have had an extension due to the COVID pandemic. The IMI has agreed to give us a 1-year extension so that we can carry out the clinical work and recruit patients and do all the imaging and biochemical marker measurements. So on this slide, you see the patient council. The patient council come from the UK, from the Netherlands and Norway. This was set up at the very beginning of the project, and the idea was to involve the patient council in all the research activities of the consortium. The role of the patient council is to help improve the quality and sustainability of the outcomes and impacts identified in the approach proposal, providing expertise on real life with osteoarthritis. These patients have osteoarthritis. A couple of the patients had rheumatoid arthritis. They went into remission, and later on they developed OA. So these are people who actually live with the disease. They want to be called patient representatives, and they actually participate in all of our consortium meetings. They were important contributors to the original clinical trial setup, and they participate in the process of recruitment and retention for the patients, actually meeting face-to-face with the patients being recruited in our 5 clinical centers. They are also a peer resource for trial participants, and they contribute to the newsletters and actually volunteer their time to be contacted. So this is the experience as summarized in this slide. The approach experience, basically the individual patients come from different European countries. There is currently no structure for the interaction and relationship with the approach researchers. We organically meet and interact with them. In fact, it's only this year that we couldn't have a face-to-face meeting. All previous years, we were able to spend 3 days with our colleagues who are researchers and clinicians, and also with the patient council. Sitting together at the joint sessions, discussing openly, having meals together, and enjoying a few drinks. So that was a very nice part of the social mixing that occurred. And we've enjoyed it, and so have they. They've also been doing their own things. Obviously, I mentioned the newsletter. The newsletter is an important part of them sharing their perception of how the project is going. They think it's an experience worth sharing because they want to share that experience with other patients, promote patient engagement at these high-level European consortium projects, and provide additional visibility for our projects far beyond the reaches of researchers and clinician researchers. They've identified a journal, Research Involvement and Engagement. It's the BMC Springer Nature Journal, in which they want to publish a paper about their participation in the Approach project, how they've facilitated the project, and the idea is to publish this and disseminate it both within Approach and through the official IMI channels. So the manuscript is being written right now. We've had a series of Zoom and Microsoft Teams meetings talking about the outline and content and how to change the language of the paper, which has been really technical in the initial stages, to make it appropriate for the readership of this journal. So the Patient Council believe they can make a big impact in this area, and generating the evidence to convince everybody that their contribution has been worthwhile. They have actually impacted on the way the project is managed, and patients are recruited. So their roles they see as facilitator, communicator, reflectors, initiators, and patient caretakers. These are really strong and powerful words to describe their roles. And it's fairly diverse in terms of representation, gender balance. One of the patient council members from Spain had to quit because of personal circumstances. So we've had a little bit of turnover in the patient council, but most of the core team members are the same that started back in November 2015 when the project started. they all agree that being a patient council member is rewarding, and we hope that they will be ready and willing to contribute to future projects in this area. These are the project partners, and I'm always obliged to show this acknowledgement and disclaimers slide, but I'm not going to read it for you. So how about future, current and future collaborations between OARS, OAFI, and the OA Action Alliance? So as you know, this is our first joint symposium between OARS and OAFI, and we hope to be participating in future events together, planning future events for patients, and perhaps even have a joint session at one of our future congresses. And of course, the OA Action Alliance and OARS and OAFI share some very important mission and strategic objectives. This is actually one of the slides from Professor Callahan's presentation, which I borrowed. Basically, OA Action Alliance is increasing awareness about the prevalence and seriousness of osteoarthritis, expanding education for patients and healthcare providers, people who have OA, policymakers, community leaders, etc. And they have a fantastic resource library with lots of very useful educational materials in that resource library. I strongly encourage those of you who haven't looked at their website, please look at the website and go to the resource library section and see how much rich information they have stored and accumulated. And they're focused on delivering solutions for the prevention of management of OA. And these are core things that we have in common with them. And we very much look forward to longer term collaborations with them. So this is the executive committee of OARS. They send you their very best regards and good wishes for this meeting. And thank you very much for the opportunity to say a few words.
Thank you, Ali. I appreciate your excellent speech and clear speech. Thank you very much. Later will be times of discussion and questions between us. The second speaker is Professor David Hunter. You know, Professor David Hunter is a rheumatologist clinician, researcher, whose main research focus on being clinical and translational research in osteoarthritis. He is the Florance and CopeChair in Rheumatology and Professor of Medicine at the University of Sydney and the Royal North Shore Hospital. He ranked at the world's leading expert in osteoarthritis and expert escape since 2014. He's one of the editorial board for Arthritis and Rheumatology, Arthritis and Cartilage, Arthritis Care and Research, and part of the review committee from OA for the American College of Rheumatology, EULAR and OARS scientific meetings. Dr. Hunter has over 450 peer review and publication in international journals, numerous books, chapters, is the section editor for Up to Date Osteoarthritis and has co-authored a number of books, including books on self-management strategies for the lay public. The same, is a great pleasure to have with you, David, stay here. You have probably one of the best, rheumatologist expert in OA in the world. It's a great pleasure that you stay with us, and you are a very nice person, like Ali. I know for you for years. And the title of your presentation is Research into Remotely Delivered Intervention, Dissemination of Remotely Delivered Programs, and the Joint Action podcast. When you want, David, you can start it.
Josep, Mariana, and OAFI, thank you so much. It's a wonderful privilege to be with you. It's late evening here in Sydney, but irrespective of the time of the day, it's lovely to be with you. Wish we could be there in Barcelona, but hopefully next time.
Sure.
But wonderful privilege to get a chance to speak to friends of OAFI today, and great privilege to share the podium here today with both Ali and Leigh, and look forward to the panel conversation immediately after our presentations. Firstly, just in the interest of full disclosure, I do some consulting work. I'm not going to be talking about any of those companies' products tonight. Most of my funding comes from the federal government in Australia and some from Arthritis Australia as well. For those of you that would like to read a little bit more about some of the content I'm presenting today, there's some material there. Probably the most lay-friendly, community-friendly piece would be the National Osteoarthritis Strategy, and that might be of interest to many of you. We're obviously in COVID time, so most of the presentations I'm giving these days tend to be remotely delivered, but really looking forward to the interaction that will happen thereafter, and very happy to address any of the questions that you might have. This is the overarching schema of what I'm going to go through briefly tonight. I'm going to talk about the disease burden and the impact of COVID. Talk about some of the research program that we have going on now, which started before COVID, but with foresight is probably better suited to COVID than at any other time. And then, as mentioned, hopefully we'll take some questions after Leigh's presentation. We're talking about osteoarthritis, which is a disease that affects the whole synovial joint, and an illness that presents with a person complaining of pain and functional limitation. It's incredibly common. About 1 in 8 adults, about 300 million people around the world are affected by this disease. And in general, there are huge limitations associated with the management of osteoarthritis. And I'm going to touch upon those briefly, but I guess they're best characterized. The large majority of people receive care that's often inappropriate, fragmented, and not particularly tailored to the individual, and is often reactive to an acute situation. When we compare the appropriateness of care for osteoarthritis with other diseases, we see that for osteoarthritis, about 40% of people are receiving what we would call, appropriate care. And that does not compare favorably when we compare that to many other chronic diseases. Where are we failing? Well, we're failing in a number of ways. About half of the time, people with osteoarthritis are not being asked about their pain or function. About 2/3 of the time, they're not being advocated to use exercise, weight management, education. About 2/3 of the time, they're being prescribed the wrong drugs. But we're actually doing pretty well at referring people to surgeons, but a lot of patients don't necessarily want that. And in many instances, we're either overprescribing or overdiagnosing and using MRI inappropriately. We know opioids provide more harm than benefit. Knee arthroscopy is widespread in the management of osteoarthritis, and again, is costly, harmful, and of no benefit. So there's lots of opportunity for us to improve the situation where ultimately there is a little bit too much medicine in many instances. This is ideally what we should be doing, is identifying the person that is affected by osteoarthritis and identifying what we call modifiable risk factors. So they might be overweight or obese, and we should target that with diet or exercise. Their muscles might be weak, and we should appropriately strengthen them. If they've got poor sleep or mood, potentially use cognitive behavioral therapy or exercise. So try and tailor the management to the individual that presents with the osteoarthritis. In an effort to try to disseminate evidence-based care, there are now a number of multidisciplinary programs that have been disseminated throughout the world, many of which are actually in Europe. And some of the images here feature some of the programs where multidisciplinary care is being disseminated to improve the management of people with hip and knee osteoarthritis. Now, importantly, particularly during COVID time, many of these are now beginning to be delivered remotely or through electronic delivery, including the Joint Academy, which originates in Sweden, the Healthy Weight for Life program, which originates in Australia, and Mike Hurley's Escape program, which originates in the UK, and a number of others are being developed as we speak. As mentioned, osteoarthritis is an incredibly common problem. In COVID, as a consequence of home isolation, many people with musculoskeletal conditions are beginning to adopt more unhealthy and sedentary profiles that might affect further their physical and mental health and increase pain and disability. At the same time, because they're isolating at home or because of insufficient access to healthcare, access has been limited, which may further increase anxiety, seeking some to seek alternative, less effective ways to manage their pain. So it really just heightens the importance of being evidence-based care being accessible and delivered in a way that is potentially remotely frameable. Now, we know that during COVID, the first wave, which is associated with mortality and morbidity, is associated with the virus itself. And many countries obviously are experiencing second waves of the virus itself. But irrespective of the second wave of the virus, there is also impacts of resource restriction on urgent non-COVID conditions, but ultimately also a third wave. And that in part comes about because of increasing restrictions of access to healthcare, sedentary lifestyles, and oftentimes inequity, interrupting the care of chronic conditions such as osteoarthritis. And it's in those times where remote delivery of care through, through telehealth is so important. And there's been a rapid increase in the preponderance of electronic and telehealth delivered types of interventions. And I'm going to talk about a couple of those today, which we've started rolling out over the last couple of years. The first of those is a program called Partner, where a person presents with osteoarthritis to their primary care physician, a diagnosis is made, and certain measurements are done, and then they're referred off to a remotely delivered service that provides education, a care plan, exercise and weight management, and self-management support. And that's ongoing, and again, it's delivered remotely. There are a number of ways that we deliver that remotely. Sorry. So, for example, the education is through a program called My Joint Pain. In addition, muscle strength, we have our own dedicated remotely delivered strengthening program for those people that are overweight or obese, a specific diet, and so on. So all of this can be delivered remotely. All of these are what we would consider priority treatments according to best evidence guideline care, with, in addition, some other options depending upon need for depression, anxiety, insomnia, sleep, or work disability. And that's consistent with what most guidelines would recommend. And this is an algorithm from the Royal Australian College of Physicians guidelines, which we brought out a couple of years ago, that recommends those things in green to be done more often. So that's education, weight loss, exercise, and so on. Those things in yellow to be judiciously used, but potentially reduced in terms of the frequency of use and their inappropriate use. And those things in red, where many guidelines would actively discourage their use, including opioids, viscosupplementation, and arthroscopy. Many of the interventions that are tailored towards particular deficits in people that have osteoarthritis can be delivered remotely, including by physioapp for exercise, a pain trainer for pain management, and in addition, cognitive behavioral therapy. So there's lots of different interventions that have been developed for people with osteoarthritis that can be delivered remotely depending upon what their specific needs are. Another program that we've started now about 1.5 years ago, again as part of a research program, is looking at the use of remote coaching, incorporating wearable technology and gamification after a person has had a joint replacement or spinal surgery. And this is a program we're calling the Pathway Trial, and it's in an effort to see if we can improve and enhance recovery following those surgical interventions. We know that from systematic reviews that these do provide modest but meaningful effects as far as pain and function is concerned. And it's in that context where, as mentioned, we're using exercises delivered by physioapp, we're tracking people's activity and giving them coaching via Fitbit, and also talking to them on a regular basis through Zoom and motivational messaging, as well as measuring their range of motion in those people that have knee replacements. So that's a program called Pathway. We're hoping the results of that should be available in the middle of next year. Another effort that a number of us around the world, including Krisha at Keele University and Leigh at the Osteoarthritis Action Alliance has done, is to try to pull together remotely delivered resources that can enhance care for people with osteoarthritis during the COVID time. And these include resources that can be remotely delivered around physical activity and exercise, healthy eating and weight management, pain, sleep, and mood. So that website is called jointaction.info and provides a lot of information there about various aspects of management, all of which are being delivered remotely for people who are finding it difficult to access healthcare. Another part of the Joint Action website is a podcast called Joint Action. And we've now, I think we're up to about 25 episodes. I've done one with both Ali and Leigh, and I think many of the topics are of great interest, but also are targeted and tailored towards the lay community. So that's not a professional audience in particular that we're targeting, and hopefully many of the questions that we're posing there are of interest to the audience. So again, that's the Joint Action for those people that listen to podcasts. That's readily available on most podcast sites. So again, I'd like to close in just stressing the importance of the prevalence of the disease, the disability that disseminates from that, the fact that the demographics are changing and COVID is impacting further upon increasing disability, but there's lots of different ways that we can improve care. And I've touched upon some of those that are remotely delivered that hopefully would be more accessible during the COVID time. I'd like to thank my funders, my collaborators, but in particular my team who do all of the work, and got a great privilege to work with them. So again, thank you very much for your time. Real great pleasure to have at least a brief opportunity to interact with both Ali and Leigh, but thank you very much to Josep and Mariana for the opportunity to present with you here tonight. I'm going to stop sharing my screen, hopefully.
Thank you very much, David. An excellent presentation, as always. You know, in your level, you give an excellent presentation. I really appreciate and I enjoyed, and it's a very interesting data that we can later comment with other speakers. Thank you very much, you know, David. The third speaker is the Professor Leigh F. Callahan, Director of Osteoarthritis Action Alliance from the United States. The Professor Leigh F. Callahan is the Director of Osteoarthritis Action Alliance for the United States. She's also an epidemiologist and outcomes researcher who, for more than 30 years, has worked in musculoskeletal outcome research. Her research has focused on predictors of outcomes and quality of life in individuals with osteoarthritis and rheumatoid arthritis, patient-reported outcomes and measurements, physical activity and arthritis, social determinants and health outcomes, health literacy, and complementary and alternative medicine use in rheumatic disease. She is the Associate Director of the Thurston Arthritis Research Center, as well as Director of its Multidisciplinary Clinical Research Center, titled Mitigating the Public Health Impact of OA. The title of the presentation is Delivery of Evidence Programs Remotely, particularly work with ease various patients face due to COVID, particularly individuals who are in rural areas or those with fewer resources and OAAA resource for patients. The same, thank you very much, Professor Leigh Callahan, to be with us. And when you want, you can start it. Thank you very much.
Thank you, Josep and Mariana. It's a real pleasure to be part of this group with David and Ali. And it's morning here, so good morning from the United States. Ali, next slide. So this is a slide that Ali showed, and it just talks about the Osteoarthritis Action Alliance. And I'm going to be focusing a bit on the public health aspect, because that's what we are focused on the Alliance. And we're actually a coalition of more than 100 organizations and groups, including universities, community-based groups, and we're pleased that OAFI and OARS are both members of the Alliance. And as Ollie noted, we're committed to elevating OA as a national and international health priority, promoting effective policy solutions. We focus on awareness of the prevalence and seriousness of OA and really depend on the researchers like from OARS who have done a lot of work focusing on how serious the disease is, expanding education, not only for healthcare providers and people who have OA, but also across the life course, thinking about children and education for them in terms of injury prevention, and focusing on solutions, some that have been shown in the previous slides in terms of our website and resources. We really were started out of the 2010 Public Health Agenda that was published in the United States, and we have updated that now for 2020 and launched that with, again, a real focus around physical activity, weight management, injury prevention, and self-management. Many of the things that David talked about in his presentation, and many of the things that are relevant, particularly during this time of COVID. Next slide. I've got up here a slide that talks about a number of the barriers that people are facing during this pandemic. And on the left are common barriers, and on the right is the reality for patients with osteoarthritis. Common barriers include things such as unemployment or reduced finances, and in terms of for folks with OA, that translates into hardship buying pain medications and covering medical care. Reduced transportation for services impacts all individuals, and during this pandemic has resulted in reduced access to parks or other outdoor spaces for physical activity. Limited access to medical care. Many of the things like joint replacements, particularly in the United States, were halted in the early phase of the pandemic when they wanted to make sure that hospital space was open for COVID patients. And then there was delayed access to physical therapy and joint injections. Limited ability to meet basic needs. There was more difficulty acquiring groceries and pain medications and just performing household chores. Reduced or closed childcare or elder care, and for patients with OA, that resulted in loss of reduced services of formal and informal caregiving services. Lack of reliable internet connection. Many of the things that also David highlighted, and I'll be talking about too, require access to telehealth and virtual medical care and virtual lifestyle management programs. And if people don't have reliable internet connection, it's difficult for them to get that type of access. Gyms and other fitness facilities have been closed, so people have had to go to these online measures, and that's resulted in reduced access to physical activity and reduced social support that many people received when they got their physical activity in the gyms or in fitness facilities. Increased stress, depression, and anxiety. When you think of the circle that David showed, people with osteoarthritis were already at greater risk for depression, and some of this isolation and many of the barriers, financial strains, could have led to more increased stress and depression. And notice, I noted just before, the increased isolation and the fact that people with OA were already at greater risk for that. And then just worse outcomes overall for people of color. And OA disproportionately affects minorities, both in terms of prevalence of the disease and the impact of the disease once people had it. Next slide, Ollie. People who live in rural areas face additional barriers, not only just people with OA, but all individuals. And those are some of the things that I noted on the previous slide, such as poor access to internet, or and so then it makes the access to telehealth more difficult. There are also increased rates of arthritis and joint pain in individuals who live in rural areas, as well as higher rates of activity limitations related to their arthritis in the individuals who have arthritis. Also, there are increased rates of arthritis among women, older adults, smokers, adults with less formal education, and adults who are less physically active, and adults with higher body mass index. And often in rural areas, you have an increase of individuals with lower SES or less education, and also individuals with higher rates of cancer. Next slide, Ali. So I talked a little bit about the barriers and the doom and gloom, but what have been some of the positive outcomes from the pandemic? And I think David really elucidated this beautifully in terms of the expansion of telehealth services across many sectors. And I think some of the expansion is going to remain after the pandemic is over, and we'll be able to have a more mixed thing between in-person lifestyle programs and telehealth, and that will benefit people who cannot get out as easily. Many of the in-person lifestyle management programs have transitioned to remote models. David mentioned a number, and here are some more: Enhanced Fitness, Active Living Every Day, Fit and Strong, and Tai Chi for arthritis and falls prevention have all transitioned into remote models. And then many of the programs that were already tailored for remote intervention have been promoted more widely. And those include Walk with Ease, self-directed, the chronic disease self-management education, and one that we have here in North Carolina that I like a lot just because of the title of it, Eat Smart, Move More, Weigh Less. And I think this is Eat Smart, Move More could be a good mantra for all of us. I'm going to focus a little bit more on Walk with Ease, since, next slide, Ali, since that is one that we really focus a lot on in the Osteoarthritis Action Alliance. Walk with Ease is a program that can be delivered in a group setting, but there's also a self-directed component, which is very conducive to remote intervention. This is a program from the Arthritis Foundation that's an evidence-based health intervention program with proven benefits to reduce pain and stiffness, increase balance, increase strength and walking pace, increase ability to confidently manage arthritis symptoms. I apologize for the allergies here in my voice. This program, I like the slide that David showed, that you don't know how much you can walk with the penguin until your wings are spread. And I think that would be a good one for us to share with people with Walking with Ease. But it's a walking-based program. It's a self-paced 6-week program that follows a guidebook, and the guidebook leads the participants through a range of things, including goal setting, ways they can overcome barriers they may be facing, stretching and strengthening exercise. It provides walking logs, assessments, and it can be done alone or with others in the center. Next slide, please. We have a portal that we developed in 2019 and launched where we give people access to the self-directed Walk with Ease. And once they sign up, they get motivating emails and tips to guide them along in their use. It's helped over 2,000 people in all 50 states in the United States, but we've even had people sign up from Australia and Canada. And we've expanded it to work with a number of community-based organizations and state health departments, reaching over 1,000 individuals. And we're currently developing an enhanced version of the portal that will launch in early 2021. Next slide, please. My last slide just focuses on something you've seen before, our resource page. We have one devoted to COVID. And as David noted, we developed with this in partnership with OAFI, OARS, and the Joint Action Partnership that lists a lot of resources. And we also have online OA support groups, Health Unlocked and the Stand Up to OA Facebook group. And the links to both of those are here. So encourage people with OA to check out the resources and the support groups. Thank you.
Okay, well, Professor Callahan, excellent presentation too. And, congratulations for all the terrific work that, you are doing, and Osteoarthritic Action Alliance you are doing is incredible. I mean, congratulations. It's an example that how we can work, and in this special time, I think it's terrific work. Do you have some questions between the speakers? Or if you have some questions, perfect. If not, I have some questions that we can discuss. We'll have more or less 15 minutes. I mean, that means that we can answer the most faster in order to have more questions, no? Do you have questions between the speakers? Or you prefer that I can? Okay, go ahead.
I have a comment. I have a comment for David, and I want to thank him for Joint Action podcast. It's the perfect length. It's really interesting. When I go exercising, I actually put my headphones on. I listen to one episode running out away from the home to the local village, and I listen to another one coming back, maybe a few tracks of classical music in between. So thank you, David, for really providing excellent educational experience and opportunity to keep updated with all of our colleagues through Joint Action. I think is probably the richest source of osteoarthritis-focused podcasting out there. Thank you, David.
Appreciate the support. Thank you very much. I have a question for Leigh, and I hope it's something that she's thinking about, and I'm pretty sure she is. Is one about the challenges of remote delivery, particularly through internet, when oftentimes we don't have a community that has great health literacy, and what we should be focusing on doing better to improve the quality of our resources for the diverse communities that we serve.
That's a great question, and I am thinking about that a lot. And I don't have all the answers yet. I think the key is going to be to partner with the diverse communities and not think that just the same way that Ali's beautiful presentation about the patient engagement and approach, you've worked with patient engagement. I think this is going to be done working with the various communities and thinking about letting them tell us how we can best do that. So we are starting in the Action Alliance to develop some partnerships where we can go into some rural communities and talk with people who are living in the rural communities and talk about how they would like things. And we're also working very closely with Movement is Life, which is a group in the United States that's focused on getting individuals of color more active and moving. And we are specifically trying to partner with those groups and see if we can have involvement from them to think about it. And we also just recently, and Ali, thank you so much for your participation in our strategic planning. One of the things that came out of that was that we needed to have more diverse membership organizations in the Action Alliance that represent diverse communities, because that's the way we can get more volunteers to help us and engage in this and think about this. So I don't have the answer yet, but I have an answer about how we're thinking about getting started.
Okay, I have some comments. Leigh, I really enjoyed your presentation and also your programs. We will love to share these programs also with our patients and Spanish community. Do you think that could be possible to use or to share and, with our patients and to Spanish community?
We would love for you. All of our products are free, open, and there to be shared. Now,
Okay.
we don't have all of our products translated into Spanish, but we would love to partner with someone who would like to translate them because we want everything disseminated.
Perfect, because OAFI can help to you in this issue because we have a lot of Spanish community following to us, no? In Spain, of course, but also in all the group from PANLAR, a special center in South America, no? Or even United States, that is a lot of Spanish community, no? I take your promise. I take your and Mariana, he will contact to you soon.
Great. I actually have. We are so interested in having the Spanish that we have a grant under review to try
Perfect.
to do a
Perfect.
Spanish website. So we'd love it.
Perfect. Thank you. For David, that you has also excellent presentation as always. You have a question. I have some questions, no, but. In your experience, elderly people, it's one of the problems that elderly people, do you think that they are prepared to use technology for physical activities and the management of disease? Do you have some problems? Because sometimes happens to us, in our patients, that there is elderly people that they manage very well the new technologies, but not all of them. Do you have experience about that, David, or how can manage this issue?
Yeah, it's an important question, Josep, and it's something that we are thinking about a lot, particularly as it relates to the efficacy of the technology and the comfort and confidence that people have using technology for the delivery of care. So, at least in the population that we serve in Australia, the saturation of internet has reached pretty much 90% of the community. One of our greatest sources of recruitment for our trials is Facebook. And my understanding is that, approximately 2/3 of older adults are on Facebook. And so the prevalence with which, technologies like Facebook, the internet are being used is superb. I mean, some of the other, I guess, challenges that we're facing right now is not just necessarily disseminating information through the internet, pushing messages through SMS and other messaging services, but also tracking activity and coaching people based on their wearable use. So, obviously, I'm quite comfortable putting my Fitbit on, tracking my activity and sleep. But for a lot of older adults, they probably prefer not to do that. They probably prefer not to have a smartphone on them at all times. And so some of the more tangible assets that we use to monitor activity, to track sleep, some people don't necessarily like. But horses for courses. I think sometimes we need to have different solutions available for different preferences. And I would not suggest at any stretch of the imagination that remote delivery should completely replace face-to-face care. But in this instance, particularly during COVID, where oftentimes face-to-face care is not an option, it's oftentimes a very good solution, particularly in a technologically literate community. But again, that's not everybody.
Perfect, David. This is for Ali. Ali, about the approach. Two questions. What do you learn? Because it's a good experience with patients. What do you learn? And what is the next step from the approach project, Ali?
Great question. Thank you, Josep. So what are we learning from the patients? The patients giving us feedback about how we actually present material to them. So they tell us about how we pitch the information. So if it's not clear, it's actually good training for us because we can learn to be much more media savvy and ensure that the way we use scientific language is pitched at the right level so that even policymakers can understand. So part of it is adjusting the language and making really complicated things really easy to understand and presentable in a nice package. That's what we're learning. They're learning a lot because they're learning about how the project is potentially going to impact on their condition and future treatments. In the initial part of the IMI program, there wasn't patient participation. So indeed, in a lot of the earlier framework programs of the European Commission, the patients didn't have a role in consortium projects. Now it's absolutely mandatory to include patient participation if there's going to be a clinical trial or a clinical study, and patients need to be, you need to convince the reviewers and the panels for the funding body that you involve the patient, not just to come and participate in the project meetings, that you involve them in the development of the original concept for the research. That, I think, is an important step change.
Perfect.
I think that's where patients can and patient organizations such as OAFI can have a big impact on a research consortium.
Thank you very much, Ali. And you know that we are very happy to collaborate with you and with ORC and also with David and also with Osteoarthritis Alliance. I mean, we're happy to collaborate with three organizations. And there is another question for all of them that you can answer for you one, is that the perception about the COVID, how can influence to the clinical trials? Because when we make a survey, and one of the things that patients, they like to know is the new treatments, the new therapies, no? In your perspective, do you think that the COVID problem in the world can stop or delay the research, special clinical research, and could be a problem for the new treatments available? Do you think, what do you feel about that? Of course, that maybe not there are a lot of data, but what is your feeling? Can stop? Because we see, for example, our experience is that with the pandemic, sometimes people, our patients, they don't like to go in a clinical trial, no, because there is the pandemic, no? What do you think about the effects about that?
Yeah, so it's a good question, Josep, and I think it would vary dramatically by country and depends obviously where the trials are being run, but we do quite a number of sponsored clinical trials. We had a spike of COVID during April, and during that time, the hospital sensibly said, we need to put clinical trials on hold so we can focus on acute care delivery. We've been fortunate now that we've flattened that curve. We've had very low case numbers basically since late April, May, and since that time, our clinical trials have been able to resume. But that's obviously Australia. We're very fortunate with regards to our COVID case numbers, and many of the other clinical trials that I'm involved in that have sites, for example, in the US, in the UK, have understandably had to slow down considerably as a consequence of increasing case numbers. So I think therapeutic trials are being slowed, but many of them are still going on, and I think some of them are beginning to take advantage is probably a strong word, but beginning to look at the opportunities for conducting their trials in countries that are less affected by COVID.
Perfect, David. Thank you very much. And maybe because we don't have more time, we have 3 or 4 minutes, and we can go 1 hour more, but because there's a lot of questions, no? But one of the things that maybe, this is also my experience, but we would like to share with you is what you think about that, is that all these activities that you are doing, the 3 organizations that are excellent, the same we are doing in OAFI, no? Sometimes the politicians, they don't know. They don't know about politicians responsible for health issues, saying that they don't know for sometimes, no? Because we are doing a lot of good activities and health, a lot of patients, especially in pandemic, no? I think could be thinking in the next future how we can arrive generally to the politicians saying that the organizations like us, we are doing a lot of activities, and we did a lot of activities in the pandemic, COVID, and probably it depends of the time of the COVID. But I think you have some idea that how we can we can, approach to health authorities to explain our work that we are doing? Yes, Ali, go ahead, please.
Traditionally, scientists and clinicians have refrained from getting involved in this sort of political activity. And this is a hot topic right now because of the impact that COVID is having on science and research. So we haven't done enough, in my opinion. So I'm not expressing the opinion of the organization. This is my personal opinion. Scientists and clinicians have really focused on excellence. And that's what ultimately we are paid to do. That's what motivates us. But we're now facing a situation globally where potentially the spread of inaccurate information, fake news, etc., is something that we need to take more seriously. So that's one side of it. The other side of it is actually more engagement with policymakers and politicians. I have been to the House of Commons. When I worked in the UK, my previous institution had the opportunity for us to go once a year to Set for Britain, which was an evening soiree event with politicians, members of parliament. I went to 2 of those, and really nobody knew anything about osteoarthritis from that select group of MPs who were there. So they're asking me, what do you do? What is your work on? So I would focus on my own area, but not in too much detail. So really, politicians, we have a lot of work to do.
Sure.
Summarize.
Some comments, David and Leigh, about that, the last comments, because we don't have more time. Do you have some comments, or?
Leigh, you go first.
Okay, I agree with Ali wholeheartedly. I think we need to do more. And I think a lot of efforts, actually like OARS's effort to really focus on the burden of OA, the more we can get that out there in front of politicians, the more they'll understand the disease. And my one other comment is I think we need to work with other chronic diseases and not always go in silos. And if we're working with diabetes and cardiovascular disease, because so many people with those 2 highly prevalent conditions that people think about a lot more, so many of those individuals have OA, and OA can be a barrier to some of the things that are beneficial for those diseases. So I would encourage
Perfectly.
with a united voice.
Yeah, and I very much, thank you, Josep. I very much agree with the points that both Ali and Leigh were making. And I think in addition, I think it's just really important to continue making the message, keeping on knocking on the doors, unless someone's speaking to them. And again, with a united voice, similar to what Leigh was saying, I think that will fall on deaf ears. We've been preaching about the healthcare impacts, the costs of the disease, the fact that many people are unemployed or living in poverty as a consequence of their arthritis. But I think as importantly, we need to just continue building those relationships, identifying politicians and policymakers who are affected by the disease so that they have some more personal interest. But really, and this is hopefully very near and dear to your heart, Josep, is harnessing the consumer voice. I don't think we have necessarily done that as well as we could in impressing upon politicians that there are large segments of the voting community that are affected, that are neglected, and that they could do a lot more for.
Okay, we need. I appreciate David, and I agree. Well, the time is over. And for me, it's a great pleasure again for the 3 speakers that you stay here. I cannot say more than thank you, thank you, and thank you from my heart. And all the people from the staff from OAFI and a lot of the patients that we are following to us. I really appreciate your time, your expertise, and your excellent work that you are doing in your 3 organizations. That is an example for us. Very happy, and thank you, thank you, thank you.